Hello, my name is Harrie Weinans.
My name is EFPIA van Helvoort.
I'm going to interview EFPIA for a couple of minutes about the first publication that EFPIA recently finished about the Approach Consortium. And the good part of it is that this is the first publication where the actual complete data set was used, where we followed 300 patients for a period of 2 years. And well, as you might know, the Approach Consortium is all about predicting whether patients that have osteoarthritis become progressive or not. And the final goal is that we want to include patients so that they can have the right therapy. So EFPIA, you looked at two outcome parameters, what was pain and structural changes.
Yeah.
Can you tell a little bit more about those outcome measures and how you measured those?
Well, pain, I think that's obvious for everyone what pain means, but we measured it using a questionnaire. So patients had to fill in the same questions at the beginning of the study and then during the study and at the end of the study. And then we evaluated whether their pain got worse. And for structural changes within a joint, there are a lot of parameters, but for this publication we used the minimum joint space width, which is the space between the bone of your upper leg and the bone of your lower leg. Yeah. So that's what, and then the minimum.
And you measured that on an X-ray?
Yes, we measured it on an X-ray.
Yeah.
It's quite automatically.
And how accurate are these measures? Suppose you do that 10 times on the same day or 10 times in a week. Is there a lot of variation in these measures, or is it really good reproducible?
Well, for pain, there is a variation, obviously. I think it's easy to imagine that sometimes when you have a bad day, you might complain of more pain than when you have a good day. And for joint space width, it's actually very accurate. Yeah. If you have the same X-ray measured by two people, then there is a variance. Well, the variance is 0 to 1, which 1 is great. It's 0.75 to 0.99, something like that. And
so the goal of the study was to use certain algorithms, mathematical algorithms that we call machine learning. And by those machine learning algorithms, we could better predict which patients become progressive or not. Yeah. And so was there a good outcome? Is machine learning really the way to go? I mean, I would think, okay, is this the new way of say, getting patients into a clinical trial, or what's your opinion on that? How good were the outcomes in short?
Well, I think it is a new way to include patients, not only in the osteoarthritic field, but also you see it more and more in our medicine science. But it takes a lot of time before you have this model which you can use. Yeah. So you have to put a lot of data in it. And then it gets more and more, it gets better. It improves itself. So
let's suppose you do a clinical study and you have, say, a study with 300 patients. And now you use machine learning on the one hand, or you don't use machine learning. So would that make the difference for a clinical trial, where if you use this machine learning inclusion method, would you then find a better result of the clinical trial than if you don't do it? Or what is your feeling about it? Or are we just scratching the surface yet?
Well, it depends on your model, of course, but also on the patients you use for the model. But I think in our case, it actually did improve the prediction of having progression. So, yeah, I think it does, yeah.
So in your case, we predicted only for 2 years. Yeah, which is still relatively short, given that osteoarthritis might take sometimes 10 years before it becomes progressive. I mean, do you have any idea whether we would do a longer follow-up, the model will still work? And can you say?
Well, if you do a longer follow-up, you have more data to put in your model. Yeah. So it will only get better. Yeah. And those 2 years is based on the duration of, generally, trials take 2 to 3 years. Yeah. So we wanted to be able to predict the progression within those 2 years to compare it to actual duration of the clinical trials.
And then there were 4 time points that we measured aspects from patients. And the first one was baseline and then after 6 months. Yeah? So if you only have those 6 months change, so to say, yeah, and you would only use that, could you then quite accurately predict what happens after 2 years? How's that relationship?
I think we didn't look at it, but I think it's quite difficult because OA is like very. Some people have indeed in 6 months very severe progression and then are stable for a few years, or the other way around, or they have a slow progression over a few years, and then you won't see an actual change in 6 months. Yeah. So I think 6 months is quite short.
Yeah. So could you already see in the data that you have that there's really different patients, not only in terms of how fast they progress it, but also what type of pain they have, or that some of them have only pain and no structural changes, or the other way around?
Yeah. All those things you mentioned, we can find in the database. So there are patients with very fast progression. There are patients with almost no progression on structural changes, but also patients with severe pain, patients with almost no pain, and also at 2 years they almost have no pain. Yeah. So it is that the variability is quite high. Yeah.
So now we have all this nice data. Yeah. So what's next? I mean, should we just dig in those data for another couple of years? Is there a lot more we can do with that data? Or is this the end of approach?
No, I think there's a lot we can do with the data, because we also have, we're just mentioning 2 outcome parameters now, but there are more, I think more than 50 outcome parameters. So I think it's a really valuable database to also look at subgroups, looking specifically at patients who do have severe progression of their pain, what makes that they have that progression. Yeah. So I think indeed that...
So if we throw in those other 50 parameters, we might be able to make much better predictions. Yeah.
Yeah, well, maybe, but that's,
Okay.
The more you have, the better it gets. But
okay. I think that's a good end of the story. Thank you.